Hi, everyone. Welcome to A Healthier You After 40. It's a summit aimed at empowering you with natural approaches to hormone balance, increased energy, better moods, and a fit and fulfilling life. I'm Linda Lukovic, your host, and I'm here with Dr. Taylor Bean to talk about health after 40, including hormones and functional testing. And so we're going to dive into that after just a quick intro. So Dr. Taylor Bean is a naturopathic doctor and owner of Tailor Made Wellness in Salmon Arm, BC. And she is a mother and is also over 40s and experiencing hormonal changes herself, as well as many of her clients. And Dr. Bean worked overseas, I thought this was really interesting, in Singapore for 2 years, which improved her skills, especially in the area of chronic illness, as she saw various patients in Southeast Asia, India, Australia, and in areas where they weren't able to get the care that they needed. So such an interesting background. So really happy to have you here today to talk about health over 40. So welcome.
Thank you for having me. Very exciting because this is actually airing on my birthday, which is very cool. Feb 3rd, my
Awesome.
41st birthday. So I'm newly into my 40s, but yes. So thank you for having me and talking about hormones and women and women's health and even what we as naturopathic doctors and functional practitioners can support women with that they may not realize is out there for them. And here in Salmon Arm, there's only myself as a female naturopathic doctor. So hormones is certainly becoming a larger area of that I'm supporting women with. So
That's great. I'd love to hear just a little bit more about yourself and how you got into naturopathic medicine. I'm sure everyone else would be curious as well.
Sure. Well, I guess everyone's journey is a little bit different. I mean, I journeyed to get into naturopathic medicine. I always knew that something around nutrition to, I was varsity athlete, so into that aspect of health. And when I looked at all the different professions, nothing really stuck. Even becoming a medical doctor was not something that I felt rigid. Each profession felt rigid to me, be it a nutritionist or be it a physical therapist or whatnot. I wanted just something where there's a broad scope, and naturopathic medicine has that. And so once I got into it, I realized really how broad it is, particularly here in British Columbia. So once I had children, which my son was born in Singapore. So that's really where my journey and my practice started. And children, babies, pregnancy is really where the beginning of my journey started as a naturopathic doctor, still remains. And as I age now, hormones is certainly becoming a lot more interesting and wanting to know about. Pediatrics is a very large part of my practice. But hormones and whatnot is becoming larger, certainly. So it's kind of the beginning of my career started overseas, and that taught me a lot of things, which I brought back here now, being in Canada now since 2016. I'm practicing after my second child was born. So so it's been quite the journey. And now in Salmon Arm, quite new, opening the clinic and being here. So to serve the population has been incredible, because this community is growing as well. So lots of new families and whatnot.
No, that's great to hear. It's so great to hear all these different options out there for women, because I know so many women really just don't realize what their options are, especially over 40. And so many people explain away the way they feel. Oh, I just had a baby. No wonder I'm tired. Or, it's normal to not sleep well at this age, And so, it's good to really talk about this and know that there are options and you actually can feel better.
Absolutely. And I think because what we seem to do is we seem to normalize abnormalities, which we don't need to be doing anymore, and say, just live with it, or my mother went through it, or my grandmother went through it, and therefore I'm destined to also go through this. And that's not necessarily the truth. You can have the opportunity with certain tools and teachings to thrive and to feel your best. And you don't need to even for myself of going through pregnancy and labor, not necessarily are you destined necessarily to have a labor that's very difficult, because there's tools and tricks that you could potentially use that you weren't aware of.
Okay.
Your menstrual cycle doesn't need to be painful or very, very long. To then going through menopause, does that mean that you have to have hot flashes? Does that mean that your libido needs to be low? Does that mean you're going to be sweating the sheets every single night? Not necessarily. We can normalize that, but we can also then know that there are things that to optimize that, and not realizing that those tools are there for you.
Yeah, no, exactly. It was funny. Something just popped into my head, and I remember a lot of women kind of complaining about very heavy periods and just feeling like they had to sort of deal with that.
Right.
Do you mind sort of walking people through that a little bit, and just what happens to your periods when you're in your 40s, and what is normal, what's not normal? Because I think that's confusing.
Right.
People don't really know, like, is that supposed to be happening or not?
Well, yeah, depending on what we're dealing with in terms of length of your menses, be it, are we dealing with endometriosis? Are we dealing with fibroids? Are we dealing with PCOS?
Yeah.
And really determining if that's what we're dealing with first, anything that, we need to do further investigation with. And then some women, yes, they'll either lengthen or they'll shorten, and either the bleed will shorten, or the cycle itself will shorten. So be it, you could be at 29, 30 days. Now you're going to 26 days, or maybe you're going to 30, 40, 50 days until you have a period. So it those alterations in terms of what's happening to your hormones within the cycle, happening within the luteal phase or the follicular phase, what's happening to those hormones, how are your ovaries responding, and producing, have you had, hysterectomy, oophorectomy? Has there been something that, or you've had,
what was the second term you just said there? Oophorectomy?
Oophorectomy. So you've had your ovaries removed.
Okay.
So, there's surgeries that have happened, so that then therefore those can change, your cycle. And so this is why detailed, health history follow-up lab, potentially imaging, is important to then come to determination of maybe the cause of what's happening. So then therefore you're utilizing the appropriate treatments, versus when everyone has a long cycle or menstrual, then we do X with everybody. And that's just not necessarily the case. You are an individual, and therefore your treatment should be individualized. And be it that's going to be the use of hormones, or that's going to be the use of maybe acupuncture, or maybe herbals, or your nutrition, or maybe your stress. Like there's so many things at play that are uniquely to you. Yes, genetics can play into that, but it's just diving down each of these pathways to then figure out, okay, what is it with you that's creating this issue? So
yeah. And you sort of mentioned testing a couple of times. So I'm sure people are thinking, okay, well, what would I go and get tested from you, and what can I get tested through my doctor, and what's the difference, and what are the benefits? Do you want to start there and talk?
Sure. So, well, when I have a woman come in, obviously the first thing you're going to be doing is an assessment and a full health history. When you see a naturopathic doctor, it's going to be about an hour, maybe 75 to 90 minutes. It's your first appointment. So people think you don't need that much time, but you actually do, to really figure out and look at all the systems and figure out what's going on from current to past. And so when a woman, starts talking about certain symptoms, then let's go down that track of, okay, do we think that we are perimenopause? Are we menopausal? What does that mean? I mean, so perimenopause can happen as early as 30, which is,
30 now. Okay.
Which is early, very early. But when we have a woman that starts having those symptoms, then with that is capturing that is then the decision of using, which we'll get to, is using of hormones. Sometimes in terms of prescribing hormones, hormone replacement therapy, HRT, can be due to your age. But then we also want to just go on what's happening with the cycle, which may not be due to age, in terms of what we're doing. But there's some in terms of when you go into perimenopause, or rather menopause, in terms of your age may depend on dictative
Right.
of what we start. So
Yeah.
the symptoms that, we'll discuss first of the assessment, of course, will be things like your sleep. Are
Mhm.
you unable to fall asleep, or are you waking multiple times
Mhm.
in the sleep and you're not able to have a restful sleep?
Mhm.
Your mood, are there mood changes that are happening? Angry more so than
Yeah.
typical.
Mhm.
So those things are important. And for some women come in recognizing that is something that is just not normal for them, and just like
Yeah.
really upset with themselves, that I'm angry all the time, incredibly irritable. What
Yeah.
is wrong with me? Essentially. And it's like, well, there's
Mhm.
nothing wrong with you. We're going to, figure out what hormonally, or there's something else that's dictating that mood changes. Hot flashes. Are they warm?
Mhm.
How cyclic are they? Are you sweating the sheets at night? What's happening there?
Okay. Yeah.
Waking. So metabolic changes. Are you finding that around the midsection that, that you're holding more weight? Or you're I'm doing everything and I can't seem to kick it. What's happening? Sexual symptoms, your libido. Do you find that there's a drop in your libido?
Mhm.
Energy decline, what's happening with your energy? So just running through that assessment first and seeing what are we dealing with. And then of course, that menstrual cycle, the
Mhm.
length, the sequence, the
Mhm.
flow, the heaviness, it changes with everybody. Has it recently changed? Is this your normal since you were 20? What is normal to you? Because no one is a walking textbook. So
Yeah.
you need to sort of move
Yeah.
away from the textbook and just decide what's normal for her.
Right.
So then getting into the lab testing. So what's important to know about lab testing is it may not necessarily correlate to symptoms. So we might actually use lab testing to establish a baseline.
Okay.
But if your menstrual cycle is a little bit erratic, then that's where it's difficult to use testing
Mhm.
as that gold standard. This is what's
Mhm.
happening to you all the time. But if you're
Yeah.
having an erratic menstrual cycle, then your hormones will change as well. So it's good to have a baseline. It's really good if you've never done, and let's say you're in your late 30s and 40s, to do blood work and just get a baseline now, because
Mhm.
you're going to be moving into transition and changing of those hormones. So it's nice to have versus,
Yeah.
your menopausal, at that point, it's like, well, let's know what is before and even perimenopause. Let's do some blood work. So
Okay.
for
So at the
some,
age of 40, you think, like, right, sort of
yeah,
when you get
it'd
into
be
your
if
early 40s, get your blood checked
yeah,
on the
get your blood
hormones.
work and start, and let's get a
Okay.
baseline for
Yeah.
you. Even though there aren't any changes, so that's for that age category, nothing's
Mhm.
starting, no changes. Let's get a
Okay.
baseline,
Yeah.
and then, be it even annually if you can, then do
Yeah.
annually, and then
Yeah.
have that continuation, and you can have that measurement that you are comparing to in a time period where there
Mhm.
are no changes. And as you're aging, there are changes, or no changes. So then you at least
Yeah.
have that baseline of you.
Yeah.
So it's really good to, when I have late 30-year-olds, early 40-year-olds in my office, then we can capture that.
Yeah.
Otherwise, and with that meaning you still have, and if we can, for some women, and even some women in their late 30s, in
Mhm.
terms of hormones, nothing to do with menopause, but their cycle is we will do blood work on day 3 to 5,
Mhm.
and we'll do blood work on day 19 to 21. So
Mhm.
when you bleed is day 1,
Mhm.
and then you account from there. And
Yeah.
so what we're trying to do is capture what's going on in both cycles, both the luteal phase and the follicular phase.
Right.
And so we want to see how estrogen is acting, and then we want to see how progesterone is acting. And so we can do LH and FSH in both those times, estradiol in both of those times, but progesterone, we're really looking at that day 19 and 21 and see what's going on with it.
Yeah.
Because estrogen and progesterone are going to help maintain that uterine lining. So we want to see what those two are doing and see how well the ovaries are responding, because our LH and FSH are going to tell us how well those ovaries are responding or
Mhm.
not responding, because that's why these numbers will increase as
Yeah.
we're into perimenopausal states, because our ovaries are like, nope, not
Yeah.
producing this anymore.
Yeah.
I don't care how loud you're knocking on my door, I'm not producing.
Okay.
Same idea with thyroid.
Mhm.
So in that so perimenopause, even if we haven't even had any transitions yet, let's get a baseline. And so that will include your progesterone, your estradiol, your FSH, if your doc will do LH, let's also put that on there.
Okay.
Then let's look at your cholesterol. So I want to see what your cholesterol level is. Your liver activity is another one, and even your fasting blood glucose and perhaps even insulin. So we want to look at blood sugar. So we're looking at some metabolic numbers when we're doing that. And then we're seeing, be it some of those do need a little bit of support, then we'll do that at that point. But then be it that's all normal, excellent. So we have a baseline. Of course, as your menstrual cycle starts to change and you don't know when your last menses was, we're not going by day 21 anymore. We're just going to do your blood work. And so, versus if you are having a cycle, then obviously we can use those day values. But so some women I will do both, the two testing. Now, naturopathic doctors here in British Columbia, we can write requisition forms for our patients. That is not the way it is across the country in Canada. It'll be different in the United States. Some countries, you don't need anybody and you can go in and you can do your own phlebotomy and pay for it and get what you want. But in where you live, there's jurisdictions in terms of blood work. So in British Columbia, specifically, everything that I said, your medical doctor can certainly do for you. But also, so can your naturopathic doctor do those things that I just said for you as well. Yeah. And it'd be good to layer on your thyroid as well. See how your thyroid is behaving. TSH is standard. As naturopathic doctors, we like to add in also your T4 and your T3, and maybe even antibodies as well to see what's behaving with the thyroid. Because of course, if a shift in energy, a shift in weight gain, perhaps it's something else that's going on. So we want to capture all of that. So those are also good to look at as well. The T3, the T4 specifically, do know that the medical doctor will not be able to write that because MSP will not pay for it. So you do need to have it privately done. So that's sort of the lab testing that you can ask and request. Be good to do at some point and have those baselines and then go from there. But do know that it's tough to make a decision solely based on your blood work when it comes to hormone prescribing. But it will be used within the conversation though, especially as you start using hormones to then continue to test your blood work, and that's twice a year as you start being on hormones. So as you start using, if you start using hormones, it is important to maintain having those appointments with your practitioner to maintain that continuation of care. Be it you need to adjust your prescription or whatnot, or any changes metabolically at all, which may change metabolically when you're on hormones, depending which one and the route that you're taking them. But you just keep all of that data is really important for you. So yeah.
No, that's great. That's really helpful. I hope everyone wrote that down. If not, you just rewind, watch it again.
Rewind and watch again.
Yeah. So great information, because a lot of that people are probably hearing things for the first time. You may have never even looked at your labs, but that's definitely one habit you want to get into, is to take ownership, start looking at your labs, and at least track it. I'm sure there's some really good apps out there now too.
Sure. And if anything, if you have a period, if you are bleeding, then, and if then you're able to know when day 3 is or when day 21 is, then go in on those times, because when you look at your blood work, it will tell you and say, this is the value if you're in the luteal phase, or this is the value if you're in the follicular phase. It tells you on the blood work. So then if you're like, I don't know when I went in, because I will say, well, what day were you on when you went in? Well, I don't know. So go in at least. I think if you get the blood work and don't really understand the blood work, do your blood work at those certain times of your cycle, so that we can look at the values and make sense of it, versus not knowing, because those values change in the month. The progesterone will be different. The estrogen will be different depending on the time of the month. Maybe you're normal or maybe you're abnormal, but you wouldn't know that if you don't know what day you went on. So
that's really helpful.
Yeah.
Yeah, because I know I've had people say to me that their doctors told them there's no point in checking hormones because they change from day to day. So I think that's really valuable. So if you're
And
kind of
that's
taking
part of it. They
ownership
do
of,
change
yeah, by the minute,
by
don't
the
they?
minute.
Yeah, yeah. No, that's
Yes.
really
So yeah.
helpful.
Yeah.
Okay. You know what I'm curious is sort of jumping to mind is I bet there's people out there thinking like, oh, I feel pretty good. Like, is there a benefit? Like, should I be
Mm.
going on hormones if I feel okay?
Mm. Mhm.
Like, what?
So, yeah, so this is where it comes in terms of age and when you became menopausal. So, for example, let's say you had medically induced menopause,
Okay.
and be it, or you had, a hysterectomy. So, there's moments where, let's say you're 45, 46, and this occurs, or let's say your menses stopped at 45, and now it's been a
Mhm.
full 12 months without a period, and it's 12 months without a period to determine that you're menopause. So now you're 46 years old. The benefit of starting something like estradiol is at that point before 50 is to start to actually help reduce the risk of breast cancer. In
Mhm.
addition, cognitive decline.
Okay.
So there's a benefit, and it's actually standard of care to start estradiol
Mhm.
topically,
Okay.
because we can do these things orally or topically. Pre-age 50 has a benefit to doing that. So it depends on when it started, and your age dictates when, and
Right.
yes, you would start something.
Okay.
So that's where it's like, oh, I rolled through perimenopause, like I'm 45, feeling fabulous, like I had no hot flashes and whatnot. So then, but at that point, then for yourself, you should be actually on estradiol,
Mhm.
hormone replacement therapy.
Okay.
There is long-term benefits and
Mhm.
actuality of doing that. And I think because even with the cognitive decline component, for example, I mean, you can't retrospectively go back, obviously, in time to do it, and not realizing that it was a window of time that which you should have done it to benefit from it. So if
Mhm.
you started estrogen and you're like, oh, I'm 56 now, I guess I should maybe go on it. That benefit window has almost closed
Oh,
for you.
interesting. Okay.
So it's just, now you were 46, now you're 56, and you're like, well, maybe
Yeah.
I'll just start now, I guess.
Okay.
There may not be that. So if you are 46, if you're pre-50 and you are perimenopause, and things are shifting, there may be for yourself then, because who knows if you're 46 and maybe by the time you're 47, it ends.
Yeah.
That's where the monitoring comes in. And that's why working with someone
Mhm.
to maintain that, and giving you that information so you're aware, so that you're like, oh yeah, I'm 48 now, and yeah, I don't have a period
Mhm.
anymore. It's actually right. It has been 12 months,
Mhm.
because you're doing either your annual check-ins
Yeah.
to realize that, oh, yes, it's been a year since I've seen you and I don't have a period anymore. Okay, great. So this is the next step for you to optimize, because there's great research around estrogen and cognitive decline,
Mhm.
dementia. And so this is where we want to prevent something like that. If we have that information,
Excellent.
then something that's important for you to know about. So that's
Yeah.
where, having these conversations, looking at your blood work, tracking your health to determine, is it time for you or not time for you? Yeah. So hopefully that
Yeah. I
answers the
think that's really
question.
helpful. Yeah, because I think there is still a bit of fear out there around, I mean, people hear the words HRT, and I
Mhm.
think, but there's a difference between bioidenticals and
Well, yes,
synthetic.
there's
So,
a difference between, in terms of estrogen,
mhm.
oral versus topical. And there's a lot of fear that has come around oral estrogen in
Mhm.
terms of cardiovascular changes with the use of estrogen oral. But the use of estradiol topically, it is almost comparing apples and oranges as a result of the route. And so, that's where the information has come out,
Mhm.
um, more so with the WHI in terms of the
Yeah.
estrogen oral, um, and applying that to topical, where topical is going to be something different.
Yeah.
So when it comes to estrogen in terms of hormones, your option is going to be estradiol. Now there's 3 estrogens.
Yeah.
for those people that don't know.
That'd
So
be
when you
good to
do
review,
blood
actually.
work,
Yeah.
you need to do
Okay.
blood work, you're looking at one of them.
Mhm.
And that's estradiol, that's
Yeah.
E2. So you have E1, E2, and E3. And so estrone is E1, then you've got your estradiol E2, and then you have your estriol is E3. So you have all those three. And there are other companies that will look at the three, the metabolization of those three, and use that
Mhm.
information. In blood, it's only the one here in Canada. We're only
Yeah.
looking at estradiol is what we're looking at here. Other countries may offer, I can't speak to other countries, but here in Canada, it's estradiol on blood work is what we can look at. So sometimes the United States has some other things they
Yeah,
can
we
look
can
at,
leave
but we
Izzy
don't.
into from the UK, and we've got some Australia too, but we'll kind of leave
Yeah.
them.
And so
in
each
place.
country can be different
Yeah.
in what their capability, their laboratory is capable of looking at, but that's what Canada has to offer. So in terms of hormone prescription, is going to be the estradiol, and we're looking at topical. When it comes to vaginal dryness or atrophy, we want to use estradiol topically, which is really going to be what is going to be helpful for that. There isn't really anything else that can do what estradiol topically can do for you. We try to use, herbals or maybe other ointments, but estrogen in itself is probably the leader in helping with those. And in addition to your hot flashes, using hormone replacement therapy is really pretty much how we're going to kick it. There is some good research around acupuncture, sage. Of course, people look at black cohosh. There are some other areas to look at when it comes to hormones. The research is really there of its effectiveness at establishing and reducing of those symptoms. So when it comes to estrogen, is estradiol, and we're going to looking for topical. And then comes progesterone. So progesterone can be, so we have the progestins, and then we have micronized progesterone, or some people will call that bioidentical hormone replacement therapy. More appropriately to call it micronized progesterone is what we're using. And progesterone too can be orally or topically. Interestingly, it can be injected, but we're going to usually be using orally or maybe topically. Orally crosses the blood-brain barrier. So that's where it gets to in terms of helping with sleep. It can activate GABA receptors, and then that's where we can feel that sedation and sleep. And so that's where the oral will come. Progesterone can also be suppository as well. So threat miscarriages, women will also use progesterone in the first trimester, orally and suppository. So it can be used in different routes, different forms. Progesterone, you have different options with it. So progesterone itself has that sedating effect, and really protects the uterine lining, is what progesterone is there for. It's interesting too, for some women who are like, I took progesterone, let's say they have PMS, and I took progesterone and that was awful. So for some women, it may be indication to me, if we're dealing with PMS, I even think about maybe we're dealing with PMDD when progesterone doesn't go so well. Also, routes of progesterone, maybe for some women playing with an IUD instead. If we're not going to be compliant, we don't want to take it orally. You can do it that way. Ideally, I'd like to do micronized oral is the ideal, but there are a little bit more options there. You
mentioned PMDD.
Yes, so premenstrual dysphoric disorder. So it's basically a much more severe situation, extension of PMS. It's just where everyone knows when you're going to be on your period, and you don't like who you are, and so for some women, potentially will go on a medication, SSRI, as a result, and that use for that, and it may be effective, but just knowing that if you didn't do well, and that's where you'll use that as a sort of a clue too, what's going on. So, but yeah, it's the estrogen, progesterone. Naturopathic doctors, we cannot prescribe a DHEA or testosterone here in British Columbia, those that have prescribing rights, be it in not other provinces, states, that naturopathic doctors can, but a medical doctor's whom dictates the prescription of those two in itself. So yeah, those are the two that we'll usually play with in terms of women, typically together. Will be the two together, meaning estradiol and progesterone, maybe starting on just a little bit of progesterone, and then increasing dosages change, and be it what's occurring with your cycles, be it also the timing of use of these hormones, be it might only be 14 days of the month you're using progesterone, or maybe it's 6 days of the week, maybe it's every day you're using progesterone, depending where you are with your cycle. Yeah.
Okay. No, that's really helpful. So I'm wondering if people might be curious about, like, so if you're going on hormones, how long do you stay on them? Like,
yeah. So that's the thing with hormones is, in the beginning should be establishing, like, what is our long-term or short-term goals? What are we doing? Why are we even deciding to go on it? Is it for the short-term goals are going to be, well, I have hot flashes, I have insomnia, vaginal dryness. That's why I want to go on these hormones. Now, when it comes to long-term goals, it's going to be like estrogen would be more so in terms of prevention of osteoporosis. So, I mean, this is where the baseline testing as well, maybe depending on your age, where you establish, even using public health in terms of a DEXA scan, maybe you're doing something like a breast exam, a mammogram, in terms of looking at that in itself of baseline. So that's why in terms of long-term, to establishing and maintaining the need and the levels in terms of blood work, in terms of when you're on it, what are our long-term goals. And so then that maintenance of the public health component of those testing, and this is why it's not one and done. Yeah. Why it's not, here's some hormones, see ya. It is a commitment. There is a commitment here. It is to establishing the beginning of hormones should be, now we are on trajectory is going to be quite some time, years. And particularly if you're pre-50, let's say you're 47, 48, to be on that estradiol at least a minimum for 2 years, until you hit that 50 mark. Because of those benefits. And we don't want to miss out on that window of opportunity to optimize your health, because as you age, you can't go back. So you want to take advantage of that. Yeah.
Interesting. Yeah. No, that's great.
Yep.
And so you might stay on longer term, just depends on what your plans are.
Yes. Like, exactly.
This is like almost a form of self-care, like, because there's a lot of thought that goes into it, but it's like taking time for yourself to really, pay attention to this and track and do all the things and put yourself first, and because you can feel better. Yeah.
And again, the first two things I would do is the assessment of yourself. Yeah. And the next is the blood work. Just that's where you start. That's it. And then you take that, the next step is then you having someone analyze that, sit with you and dig deeper, because you're like, I didn't realize that was important, because you don't know that maybe that's an important piece of information that, you left out, and then go from there. And having the discussion around estrogens in terms of those different forms. I think it's important to note, we're not going to be doing oral forever. We would be doing topical is what we're going to be doing, that cream, and it's not every day, be it we're just going to be doing, depending on why we're using it, twice a week, is why we're using it. And so, be it that's vaginal dryness where, 2 weeks in, you're like, I'm feeling so much better. You should actually be using it longer, but not knowing that you're like, oh, I'm good, I'm going to stop. But you're actually going to be using it for a bit longer. It depends on why we're using it and what's happening. Yeah.
Okay. And so I imagine, do you use the Dutch test or saliva testing?
I have used a Dutch test. Yeah. And I like to actually use them in combination. So blood plus Dutch and comparison of those two. because the Dutch also tells us a little bit more of other things. There's cortisol on there, there's melatonin on there, there's nutrients on there. So there's other things on there as well.
Okay.
So I do the Dutch plus blood. Of course, the conversation is around affordability.
Yes.
The Dutch test just went up. They just increased their rates.
I saw that.
So we have to adjust to that, which makes it quite an expensive test. And what are we going to gain from that? What are we going to take away from that? Because sometimes that conversation is, okay, well, what will I take away from this test? Couldn't I already figure it out without doing the test? But some things come up on the test. I'm like, whew, I didn't see that coming.
Okay.
That was interesting. That actually that makes a lot of sense, for example. You know, and be it even when it comes to certain, when we look at, are there relative contraindications of using or absolute contraindications of using hormones? And so for some might be, well, those that are obese should not use estrogen. And that's sort of a conversation actually that we need to talk about, where just because you may be obese does not automatically mean that you don't get to have the ability to using something like estrogen. Because what some clinicians will do is think, well, that obesity is due to estrogen dominance, and therefore she should not be on estrogen, yet she has vaginal dryness. So we really have to, everyone on the planet should have equal opportunity to have access to these, and we shouldn't come with a bias of whom should or should not. And so that's why you run through those symptoms, because that woman, be it obese, she actually may qualify for topical estrogen used for her. And so then her symptomology then will improve as a result of using that. So I do think even as practitioners, you know, knowing that estrogen, apples and oranges, oral versus topical, and get to know that a little bit better in terms of then the application, and for patients that shouldn't be suffering, and that woman should, you know, be at access to something like estrogen for her.
No, that's so great. You've definitely made it clear that how important it is just to look at everyone so differently, because we're so different. We're so uniquely required.
So different.
Yeah.
So different. Yeah.
Thank you so much. That is such a huge amount of information. Is
awesome.
there any final tips you want to give our audience, our friends out here? One thing. Well, I know what you're going to say, but I'm going to ask you anyway. What one thing do you want everyone to start doing right now when they hit the age of 40?
Sleep, ladies. Sleep.
Okay.
It would be knowing the importance of sleep, particularly for women, and our hormones. And sleep, interestingly enough, sleep in itself is get assessment potentially for sleep apnea. And not knowing it because we don't snore and our partner doesn't recognize that, you know, we have any issues with our own sleep. Sleep in itself can potentially be affecting even hormones, hypoxia and hormones. There's a connection there. And so sleep, I think, first off, just get to bed, ladies, sooner. I know, but get to bed.
Series,
And if you find that you're not waking rested, then, you know, don't be afraid to get assessed for sleep apnea, and see if there's something around sleep that is potentially might be the core. But know that we need a solid 8 hours. Men can get away with less. Women, actually, we need more. So, be it your husband's like, wow, you sleep so much. Actually, we do need more beauty sleep. So it's okay.
Something to that. I love it. That's so great. Oh my gosh. Thank you so much.
Welcome.
That is an amazing amount of information. So
excellent.
Everyone, we're going to put the links below. So make sure you go visit the website, and the freebie link is going to be there as well. And so where can people find you?
So I am on Instagram, Dr. Taylor Bean. My website is drtaylorbean.com. The clinic is tailormadewellness.com. Would be the best ways to find me. Website and Instagram.
Okay. All right. We'll put all the links there. So
awesome.
All right. Thank you so much for joining us.
My pleasure. Yeah, my pleasure. Sounds good.